Thanks for sticking around this afternoon. It's a nice day out there. So I'm going to talk about some of the work that I'm doing at the VA, but also some of the work that's going on more broadly. And it's really nice for me to hear about things that are going on outside of the VA system. I think we get sort of stuck in our VA loop. So it's interesting to hear a lot of the similar problems and a lot of similar kind of challenges, as well as successes in the world outside of the VA. Just wanted to start off by thanking some of the funding agencies that have funded my projects that I'm currently working on, as well as the research team of collaborators, both here and in Houston and in Palo Alto. Just to give you guys a little bit of background on the VA, it's a very large system of care. All 50 states, Guam, Samoa, Puerto Rico, and many other outerlying areas. So the VA really has a broad network of healthcare, and a lot of veterans, over 3 million veterans that are seeking services through the VA. And those are through 153 medical centers, so large hospitals like we've got here in Little Rock, but also outlying community-based outpatient clinics, so kind of the hub and spoke model that Dr. Schaefer was talking about. So a really complicated network. The CBOCs are made up of VA facilities, but also contracted facilities. So in certain areas, there may not be a large enough need to have an entire VA clinic. So the VA will contract out services from those local clinics. So the idea is to have at least a minimum level of services available to all veterans throughout the country. And this is a huge challenge because, as this number shows, 48% of our veterans live in rural or highly rural areas. So a large portion of the folks we're serving are in areas that are not close to large urban hospitals. My training in telemedicine took place in Hawaii at the Honolulu VA. And if you've ever been to Hawaii, you'll know that it's pretty difficult to get in between the different islands. So a lot of the clinicians would have to fly to the other islands in order to provide specialty care services, which incurred a huge cost to both the VA and to the veterans themselves. Some of the clinicians were even flying to like American Samoa and Guam. So you can imagine the frequency of contact suffered as a result. So telemedicine was a huge contribution and a huge development in terms of healthcare services. It's a highly heterogeneous population with lots of different mental health and physical health needs. So very complex patients, and hoping to give a comprehensive care to these veterans is a huge challenge. So as you can imagine, lots of research, lots of innovation, lots of exciting new technologies emerging because of this huge need. And that sort of has led us to really try to focus on access, try to focus on how do we get services to people where they need it, when they need it, and in the ways that they need it, and the packages that they need it. And that's really opened up a lot of doors for technology, particularly telehealth, and then the more recent projects in smartphone technology, which I think is really exciting. If I haven't said that enough times, it's a very exciting field to be in right now. So how do we define access in the VA? I guess access in general is sort of the fit between the patient and the healthcare system. And this has a number of different dimensions. There's actual access, so what services are available and where and in what format, and how do the patients or the people that are accessing the care really perceive that access. So how well do people feel they're able to get those services or get the services that they need, and how satisfied are they with those services. And then there's yet another dimension, which is actually the satisfaction people have with their care. So and that really interfaces with their perception of the access. If you go to see a provider and you have a negative experience, you may have a more negative view of how able you are to access care. So these are all kind of complicated dimensions in terms of understanding how people get their services. So this is kind of, it's provided a huge challenge to the VA and something we really think a lot about. In 2011, there was a conference of folks health services researchers, including Don Fortney, who's here at the North Little Rock VA. They got together to kind of develop a state-of-the-art model, the SOTA model of access. And they broke it down into a number of different dimensions. And what I want you guys to think about as I go through these dimensions is the ways that that technology, like a smartphone or a telemedicine, might fit in nicely with some of these dimensions, and how it might help facilitate some of this access, some of the challenges to access that you have in either a large system of care like the VA, or even on a statewide level, or even a community-wide level. These are really universal themes. Okay, so there's the geographical dimension. So how far away are people? And as Dr. Schaefer was talking about, in very rural communities, you could be 100 miles from any MDs or anybody that has any sort of expertise in your area. So how long does it take? How difficult is that journey? If you're driving through 14 feet of snow, the likelihood of you accessing services is going to be very great. In Hawaii, some of the islands are not so far apart geographically, but there's a big ocean in between, and there's no ferry service in between, so you've got to get on an airplane and fly, and at the cost of about $100 each direction. So that's going to be a huge barrier to you accessing services. There's also temporal considerations. So how long is it between your appointments? Again, Dr. Schaefer mentioned the family not being able to make the drive until they had kind of generated enough money to fund the journey. So how much time is there in between different appointments? Or if you can't get an appointment, if the doctor isn't going to be coming, the specialty care doc isn't coming to your community for at least another month, and you need some treatment in between, how are you going to be able to get the care you need in between times? Waiting time in the reception. If you're a very busy person, if you've got a job, if you've got kids to take care of, if you've got a really tight work schedule, you really can't afford to be sitting in a waiting room waiting for your doctor's appointment. That's going to be a huge barrier to you accessing care. Then there's the financial costs. In the VA, we have eligibility is a big issue. So is your eligibility for services, and then your out-of-pocket costs. There's also cultural barriers, including stigma, especially in the VA and especially with mental health services. Stigma is a huge barrier to care, especially with our younger veterans. They don't want to view themselves as sick or having a problem, and that might become something that stands in the way of them getting the care they need. And then the last area is digital. So whether or not someone has connectivity, whether they're able to access a telemedicine portal or have a device in which to interact. So that's sort of the actual level. So what impacts access at a kind of a practical level? There's also the level of perception. So how much do our patients perceive that they have access? So again, to me, driving, after living on a small island for a long time, driving 20 minutes in traffic is kind of difficult. Although I lived in Houston for a little while in between, so I got over that. But somebody in Houston driving an hour in traffic isn't a big deal. So the perception of the ease of travel is different. To me, driving in snow is the most frightening experience ever. So that's really going to, even in Arkansas, when there was one day with snow, it was really a lot for me to handle. So that's really going to be different person to person. That's really going to be on an individual basis. And so you can kind of go through the other dimensions. So these different domains are really, there's really a number of different levels of both barriers that are kind of impacting how people access care. And then there's also perceived need. So how much do people feel that they need these services? So all of these different dimensions of access are really going to impact who's getting treatment and why. And the way that we see kind of telemedicine coming into the picture is at a bunch of different levels. And so, again, just kind of be thinking of that as we go through. So this is the SOTA model, and this is the model that really we use to kind of conceptualize and really think about how services are obtained by our veterans. One of the ways that we've really started to look at this more closely is through digital access. And the reason digital access is such a promising dimension is because of the flexibility and because of the kind of individualized way that people are able to interact with cell phones and with smartphone technology. It allows for veterans or patients of any sort to really interact with their providers in different ways, so either what we call asynchronously or synchronously, so they can interact in real time or leaving messages for one another in a way that adds flexibility and adds dimension to the relationship and to the access. It kind of opens up different areas. The other part that's really becoming huge in the VA is veteran to veteran, so this peer support network where people can kind of interface with one another in a way that is much more real world. You know, we want people to be interacting with their peers. We want people to be sort of able to model what's been helpful for them, or really kind of talk about things in a way that provides support, maybe at a different level that we can give as providers. There's also an emerging technology, which is what I'm going to be talking a lot about in the latter portion of this presentation, which is the ability to sort of interface with these smartphone apps that are in development that really provide different kinds of skills and different sorts of coaching that a veteran is able to access on their own time and in their kind of in the real world. So that's where things are sort of moving. And smartphones are kind of an exciting kind of new frontier for healthcare service delivery. And people are just sort of beginning to recognize the potential of these apps. Medicine is a little bit ahead of behavioral health, and medicine has really sort of laid the groundwork for a lot of the psychiatric and psychological apps that have been developed in the last couple of years. As of November 2010, obviously this stat is a little bit old, over 8,000 medical related smartphone apps have been launched. That's a huge number. And they've been in sort of a number of different domains, some administrative apps, some medical management. Lots of data is available for research on these particular kinds of apps, so scheduling, provider coordination, and then symptom management over time, particularly for chronic diseases. There's some different attitudes about medical apps. Fear that they may replace human contact, so people have some concerns about whether or not this is going to be sort of a less than kind of an approach. So people's interaction with their doctor is going to be replaced by this device that really takes the provider out of the picture. So people have expressed concern. And there may be some individual considerations about whether or not somebody is appropriate for using a medical app. So are they able to use the phone? Do they have the manual dexterity to use the phone? This is important for some of the older patients we see. Are there visual problems? Are they able to see the app and see the different icons that are on the app? Persons who have anxiety about technology, that might, particularly if you're doing a mental health intervention with somebody who's already pretty anxious about their lives and uncertainty. So adding an extra level of anxiety related to the app is you probably want to avoid. Do they have kind of the practical capacity to maintain the device? As I'm starting off into this realm of research on smartphone apps, one of the concerns is the safety of the smartphone itself. So if we're providing a patient with a smartphone to use, are they going to be at risk of having that device stolen, or are they going to be in a situation where they may be in danger, or not be able to charge the phone or to keep it up and running. Particularly for more expensive the iPhones and the Androids, which is where the platforms where you often find these apps, are people who need them going to be able to afford to kind of maintain the data plan required. And also the age and interest. We see a lot of interest among our younger veterans. Some of the older veterans are a little bit apprehensive. Some of the younger veterans think it's no problem. It's something they do in their day-to-day already. So there's really a lot of different considerations when you're deciding whether or not this is an appropriate intervention. So as I said, a lot of what we know comes from the medical field, and we're just starting to see research on mental health apps. And in mental health, it's really been a slow-moving development because of the ways that the kind of psychotherapy and technology interact. There's some concerns about the barriers to getting the kind of treatment that you want. Some domains in which smartphones have been the most successful have been in the delivery of psychoeducation, so giving people information about their symptoms and about their problems, giving them the opportunity to locate resources, get skills training, have virtual coaching, and administer self-assessments. They've also been very helpful in behavioral modification, so smoking cessation and weight management. There's some concern about the proliferation of apps without adequate testing, and that's one of the pitfalls that the VA is attempting to overcome. Unfortunately, apps are developed so rapidly that there's this kind of balance that we're trying to strike between app development and testing, and some gaps. So that what does it do to the therapeutic relationship, and how is safety maintained if you're dealing with somebody who has a psychiatric issue? What do you do when someone is either suicidal or homicidal? So those are considerations as well. So the VA has started to look at these problems. We're looking at technology, trying to develop new apps. There have been some partnerships developed in different agencies within the VA, and to really looking at targeting service members, significant others, and healthcare providers. So looking at the different domains and the different places where smartphone technology might be able to intervene. This is just a kind of a schematic of all the different apps that are being developed. So a number of different apps are in the works. One of those is the PTSD Coach, which is available currently. So if anybody has a smartphone and wants to download it, it's available in the Apple Store. It's a really exciting behavioral self-management tool for veterans. It's been over 53,000 downloads, over 60 countries, and it won an award in the 2012 American Telemedicine Association for innovation. I recently submitted a grant to look at a second app that's being deployed called the Moving Forward app. And Moving Forward is also available on the web as a website that's also widely available. So if people are looking for different tools for folks with PTSD, Moving Forward is a little bit more general for anxiety, depression, PTSD, and it's geared specifically towards veterans. But it's also available on a smartphone app, which is what I'm going to be testing. And I have it on my iPad, so if anybody afterwards wants to take a look at it, I've got it. And it's just, here's some screenshots of the app. I'm running low on time, so I'm trying to speed up. And the project that I'm proposing that I've just recently received word that it will be funded is going to take a look at some of the ways that the app is able to facilitate engagement in psychotherapy, looking at some of the ways that it facilitates symptom improvement and how it helps folks going through an in-person treatment continue to practice their skills, and if the app is actually able to help improve symptom outcomes. And the last aim of our study is to look at feedback from the veterans after they've gone through the study and use the app sort of in the process of therapy, how well they like it, and what feedback they have for adjusting it and adapting it. It looks like I'm out of time, so that's, I guess, a good place to stop. I guess here's future directions, so you guys can move that slide. Thank you guys so much.
Thank you. Dr. Schaefer, before the meeting started, talked about he was rotating between children's UAMS and here, so I guess he had to go back to one of the, oh, there he is in the back. Oh, okay. Come on back up real quick if you want to. I'm sorry, I didn't see you slip back in. I'll open it up for questions if you have